Paul, I got a couple for you.
Great.
I'm on a roll. Better wipe.
Oh, you even found one that's kind of episode concordant. Great. All right. What else you got?
Yeah, this is the whole. This might be a theme. Why don't poop jokes ever get old?
I have several theoretical answers that I'm not going to embarrass myself with. Tell me.
They're always number 2.
Oh, that's good. That's better than what I was coming up with.
Let me see. There was one more. Oh yeah, Paul, did you hear about the constipated accountant?
Oh, is this going to be is CPA in there somewhere? I feel like if you gave me enough time, I could make it work.
No, he couldn't budget.
That's good.
Also pretty solid. All right, not bad.
Yeah, literally solid. I mean, so that's thanks to Pun Central for 145 poop puns that are a real gas.
A little mixed messaging there, but sure. Thanks, Pun Central. Please sponsor us.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician. At least that's what his mom writes in his underwear, Dr. Paul Nelson Williams. Hey, Paul.
I've been re-upgraded. I think the last time we recorded, you were just like, "Can I join by Paul Williams, who's like a doctor or something?" Like I think it was like that level of enthusiasm. How are you, Matt?
I'm joined by this guy. I think his name is Paul.
Guys on the Zoom feed. I guess we'll talk to him.
He's got some cats.
Tonight's episode, it's a long overdue update on inflammatory bowel disease. There's a bunch of new medications out. Apparently, we've also discovered that diet actually is important. What people eat is actually important. And our guest is the great Aline Charabaty, who does a wonderful job. And Paul, before we introduce her with her full bio and our wonderful co-host, why are we here, Paul? What are we doing? I haven't asked you this in a while. What is the meaning of life?
Yeah, I don't know, Matt. It's not whatever this is. But just as a reminder to our listeners, we are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you alluded to, we are joined by super producer, longtime contributor, one of my favorite human beings, much more interesting than me or you, Matt, is the great Dr. Elena Gibson. Dr. Gibson, how are you?
I'm great. I just got a major upgrade too, a favorite human being.
Yeah, well, yeah, it is a short list too. I don't have any of those. So yeah, cherish it while it lasts, I guess.
I'll hold on to it. I'm great though. Happy to have a conversation today. We had a good talk with our guest, Dr. Aline Charabaty. She's an associate professor of medicine at Johns Hopkins School of Medicine and the clinical director of the IBD Center at Johns Hopkins School of Medicine at Sibley Memorial Hospital in Washington, D.C. She's a strong advocate for education and access to quality IBD care and advancing research through her roles with national GI societies. She was a member of the National Scientific Advisory Education Committee, Diversity and Inclusion Committee of the Crohn's and Colitis Foundation. She's the vice chair of the AGA Research Foundation and the ACG DC governor. She is the founder of Monday Night IBD, which is a CME-accredited educational platform on Twitter that brings clinicians together to discuss IBD topics. She's also a strong advocate for women in GI and the co-founder of Scrubs and Heels, which she will discuss further in our conversation tonight. So we talked to her about an update on IBD, including Crohn's and ulcerative colitis, some of the big changes in management, and the new medications that allow for more individualized care. We also discussed preventive medicine, including vaccinations and important cancer screening and surveillance, as well as the importance of diet and inflammatory bowel disease. We also review what to do in the setting of a flare and when to consider hospitalization for patients and what important evaluation to do at that point. So without further ado, let's get to it.
And a reminder that this and most episodes are available for CME for all health professionals through VSU Health at curbsiders.vsuhealth.org. Aline, thank you so much for joining us. We've been talking a little bit off mic, but now it's time to bring the audience into this. And they want to know, what is a current hobby or interest that you are enjoying?
So in terms of hobbies, we started raising chickens a year ago. This started after a trip in Japan, and where I got to experience those amazing eggs that they have, where the yellow is orange and it's such good eggs, you can even eat them raw. And I also remembered when I was growing up, my grandmother used to have chickens, and I really liked that. So we decided to raise chicken. It's been quite an adventure because apparently we have a lot of hawks and foxes in the area. Suddenly they all came to our backyard, interested by those chickens too. So it's been challenging to protect those chickens. I even had one chicken develop a bowel obstruction. The vet was absolutely excited to show me the x-ray of distended bowel, knowing that I'm a gastroenterologist. But of course, we've been enjoying the eggs. But to be honest, what I've been enjoying the most is really that I have that time in the morning where I go outside, get some fresh air, be outside in the grass, and I bring them food and hang out a little bit and really watch those chickens. They really have their little personalities. So I think I'm just getting older and just enjoying, raising chickens instead of going on long runs and traveling more. And then the other thing we've been doing with a colleague of mine, and it's kind of an extension to what I'm passionate about in medicine, is really advocating for women in medicine. We founded Scrubs and Heels, which is a foundation focused on helping women advance their career. We know that across specialties, there's still a lot of disparities. Gender disparities in terms of pay and promotion and leadership roles in societies and academia or private practice. And so we really wanted to provide a space where women can learn leadership skills, professional development tools, and network with leaders in the field, and also get access to mentorship and sponsorship from people who've already made it, if you want. And so we develop a leadership summit. It's a once-a-year leadership summit, really focused on professional development, but also on keeping the fun in that meeting, right? And we have yoga and a gala, and we dance, and we do kind of things to recharge our batteries before coming back to patient care. And we also develop a mentorship program. It's a year-long mentorship program where mentees are matched with a female leader, a male leader in GI, but also with a professional coach to really have that matrix type of mentorship where the mentee is getting mentored and sponsored and coached, all elements that are important to advance the career of women and really allow them to have a successful career that integrated with their life and their life journey, and really design a career that aligns with their vision and values. So a lot of things with chickens and girl and women in medicine and in GI.
Elena, this sounds like something you should
Yeah,
join.
right? Can you teach me how to raise chickens too?
Totally. We build a coop. We feed them. They love organic kale. So I have a little garden and we grow tomato and kale and all that. And the only thing they would eat is my organic kale. If I buy like store-bought kale, they don't like it. Lettuce, they don't like it. They want the kale. So they're very high-end chicken. And
You're like the Wagyu equivalent of chickens. Like you're like massaging them and eating them like, Whole Food stuff. That's great.
Totally. They're foodie chickens.
Sure.
Oh man. Wow. Well, you're mentioning success in medicine. I mean, for Paul and I, success in life is like you own chickens and you have a garden. I mean, that's just like I have failed in both we've talked about these things many times on the show, Paul, and I think all our guests are just more well adjusted than us. They've got it together. They're gardening.
1,000,000%. The plan is always like, what is your dream? It's like a Wi-Fi and a cabin in the woods, and like that's all I need. And yet I've achieved neither of those things. So yeah, good for you though.
All right. Well, we should get to our first case because we have a lot to talk about. Elena, would you do the honors?
Yeah, happy to. So our first case, we have a 24-year-old female. She has a past medical history of asthma, allergic rhinitis, seen for intermittent constipation and diarrhea. She has about 3 or 4 loose bowel movements, some days followed by 2 to 3 days with no bowel movements. She also describes intermittent blood in her stool, primarily on the toilet paper, associated with some bloating and pressure in the stomach. She describes some tachycardia that her Apple Watch told her about, and really it happens with minimal activity. She also has some anemia that she's taken an iron supplementation for, but that worsens her constipation. So thinking about this case, what signs and symptoms would raise your concern for inflammatory bowel disease?
We're here to talk about IBD, but the one thing that I want to say is anytime we see blood in the stool, even if it's only on the toilet paper, which is often related to hemorrhoid, we take blood in the stool now very seriously. Even in a young person, we know that colon cancer has been on the rise in young patients, even those without a family history, without any genetic risk factor. So blood in the stool should never be dismissed, and we need to always evaluate it, and that would include a colonoscopy. So I'm going to put this out there. Now, with her mild iron deficiency anemia, I mean, young women often have iron deficiency because of menstruation, but a GI cause of anemia should still be considered, especially when the anemia is severe, not responding to oral iron, or in the context of the GI symptoms that you described. Now, going back to those GI symptoms, they're really not very specific, right? We have bloating, alternating constipation, and diarrhea. And my first thought in a young person would be irritable bowel syndrome, or maybe lactose intolerance, or celiac disease, or H. pylori. So I might not think about inflammatory bowel disease first on my list, but it's really the bleeding, the blood, that's really going to make me want to evaluate things further. So just to kind of take a step back, we typically think about IBD in patients who present with diarrhea or bloody diarrhea. But I like this case, and I like the fact that you're presenting this one because constipation can also be a symptom of inflammatory bowel disease, especially patients with Crohn's disease who have a stricturing phenotype. So when Crohn's, has been unrecognized or untreated, or some patients have a tendency to develop strictures and obstruction, these patients will often present with constipation and bloating, and often their Crohn's disease Crohn's disease might not come to mind. Often these symptoms are overlooked as just functional constipation or IBS constipation side. Even in patient with UC, we can sometimes see constipation. When, in patient with UC, the rectum is always involved. And when the rectum gets very inflamed, it can get very edematous, and that can prevent the stool from flowing properly. And also, I've seen that in patients who have longstanding ulcerative colitis, sometimes the rectum, there's structural damage that happen and scarring, and that rectum is not compliant anymore, and it's not, contracting the way it should to have a bowel movement. And some patient can have actually constipation instead of diarrhea. So again, typically we think about IBD in the context of diarrhea, abdominal pain, maybe some weight loss, but this person can totally also have IBD, really recognizing that IBD is a whole spectrum, and some patients have more subtle symptom, and some patients have like the full-blown textbook symptom. So in this patient, I would definitely get a blood count, iron studies, a CMP, celiac serology, H. pylori serology, and inflammatory markers. But I'm going to be very honest. Probably IBD was not first on my list. I'm thinking more IBS, celiac, maybe H. pylori, but the bleeding and the anemia are concerning for me. And that's why I will probably be pursuing workup, a more detailed workup.
Can you the H. pylori serology, I feel like I'd heard that was verboten at one point, and if we do that, we'll be laughed at by gastroenterologists. Has that changed, or what is the
Yeah, I knew
utility in
you
this
were gonna
particular
ding me
patient?
on that. So really, like the H. pylori serology just tell you you've been infected, right? It doesn't tell if there's an active infection. So if this patient is seeing a gastroenterologist and I'm thinking I'm going to do an upper endoscopy, I'm not going to order an H. pylori serology, to be honest, because I'm going to do an upper endoscopy. I'll take biopsy from the stomach looking for H. pylori. But if this is a patient, I've had patients in this situation where they're in college or they're getting ready to go to college, and I really want to make sure there's nothing serious, or is there something that I can treat and make the patient feel more comfortable? And then I will order H. pylori serology. If it's positive, then I'll say, well, we could either treat or do an upper endoscopy and confirm. But, you're going away on a trip, you're going for college, let's at least give you some, we can empirically treat you if those symptoms of dyspepsia or stomach discomfort are typical for H. pylori. So in a primary care setting, it might be a good first test. if you intend to refer to gastroenterologist or to get an upper endoscopy because you're concerned about the symptoms, there's the anemia or weight loss or other symptoms in addition to the bloating, discomfort, abdominal pain, then you probably are not going to order the H. pylori serology.
Elena, why don't we go to the labs and then we can
And
get
no
to the
GI
next.
should laugh at you for anything. You
Oh,
are
I give them
taking
plenty
care
of
of the
reasons.
whole patient and of so many complex medical problem, and you're trying to triage, right? How urgent is this issue, or can I do something? So all this is reasonable. It's all depending on what is your degree of suspicion and whether or not you're planning to do more extensive or invasive tests.
And then just to clarify before we move on, inflammatory markers are usually sending like CRP and ESR or just CRP, and then the fecal calpro as well from the stool?
Yeah, this is a great question. So, I typically check for CRP, but I probably should check for both. The reason is in patient with inflammatory bowel disease, not everybody mount a CRP response, right? So up to 30% of patient can be in an active flare and their CRP will be normal. And that's always kind of a note to self or, actually in my note, I'll put in this patient doesn't mount a CRP response. So I don't for future symptoms, I should not be relying on CRP to know if this patient is flaring or not. A SED rate can often be elevated when the CRP is normal. But in a patient with iron deficiency anemia, a SED rate is often falsely elevated. So I wouldn't rely on that here. The fecal calprotectin, the advantage of the fecal calprotectin is that it's more specific to the gut, right? So versus CRP can be elevated if you have, arthritis or a flu or allergy or anything. But the fecal calprotectin is more specific to the gut, and it tells me there's inflammation in the bowel. Now, it's not specific to IBD. It can be elevated for diverticulitis or cancer or even celiac disease or any infection. But in the context, once we have a diagnosis of inflammatory bowel disease, if that person mount a fecal calprotectin response, then we can follow that fecal calprotectin and monitor treatment response and monitor for flares. And again, not everybody has a high fecal calprotectin. Fecal calprotectin is mainly useful or it's mainly increased in patients with colonic disease. So ulcerative colitis and Crohn's involving the colon. It's often normal in patients who have small backgrounds. So again, that we don't have a perfect test. So that's why you often see us ordering everything and hoping that we can have one marker that we can follow during the patient's journey.
Great. That's helpful. Okay, so this patient, she gets her labs done. The hemoglobin is low at 6.4, platelets are 605, her MCV is low at 50, her liver enzymes are normal, her CRP is elevated at 79, ferritin is low at 3, as well as a TSAT of 7. You're still waiting on the fecal calprotectin. It's at a send-out lab. And she presents to the ED for a blood transfusion after you get the labs back. And they end up getting a CT of her abdomen and pelvis as well. So what findings would you expect to see on a CT if in the setting of inflammatory bowel disease or in this patient?
This is a good question. Well, I just want to say that CT probably would not be the first test I would do on this patient. I'm thinking more about doing endoscopy and colonoscopy with exam of the terminal ileum in the context of the symptom and elevated CRP. But she's in the ER and she's going to get a CT scan in the ER. So what we expect to see, whether we're dealing with ulcerative colitis or with Crohn's, we're going to see evidence of inflammation of the bowel wall and outside the bowel. So what do we see in the bowel? We will see bowel wall thickening and wall enhancement and stratification, which means there going to be layered enhancement after we give IV contrast. So once we give IV contrast, the mucosa, the lining of the colon that is inflamed and edematous is going to be hyper enhanced. It will appear white on the CT scan and bright. And then we have alternating layers of the bowel, dark and bright. So we will see bowel wall thickening and wall enhancement and stratification, but also we see evidence of inflammation around the bowel, right? So we're going to see an increase in the mesenteric vessel or vasa recta. That's the typical comp sign that we learn about in med school. We also often see mesenteric fat proliferation. It's more of a sign of something chronic. So with chronic inflammation, like IBD, we'll often have this mesenteric fat proliferating. And sometimes we see some small lymph node around the area of inflammation. So in this patient, I expect to see, if it's UC, I will expect to see the colon being thickened and enhancing. In a patient with Crohn's disease, Crohn's most often affect the colon, the ileum, or both. So we'll see what this patient will show us. Now, in the ER, we often don't have access to something more than a CT. It's quick. We're able to get that test quickly. But in terms of following up patients with inflammatory bowel disease, we want to minimize the use of CT because of the radiation, and then we have new exciting technology that is not available everywhere. But you might have heard about intestinal ultrasound. I know you were asking me about this before we started, and what intestinal ultrasound is basically an external ultrasound, and it allows us to look at the small bowel and the large bowel, but mainly the last part of the small bowel, the terminal ileum. So very useful for Crohn's ileitis and parts of the large bowel. And it allows us to, it's not invasive. There's no contrast. There's no oral contrast, no IV contrast. And it can be done at the bedside, and we can right away have the result and see the bowel wall thickening, the hyperemia, the Doppler blood flow, etc. So evidence of inflammation. And this is very useful when we're monitoring patient later and see if they're responding to treatment, because then in the office, we can take a look with our ultrasound machine and tell the patient, things look really good. You are in remission. The inflammation has healed. That is such a useful way to know right away how the patient is doing, not having the additional cost of CT and MRI and scheduling and having, test results several weeks later and the contrast and all that, So it really decreased some of the burden of taking care of IBD for the patient. It decreased the number of appointment and visit they have. But also for us as clinician, it allows us to make decision right away. If I still see active inflammation, I can adjust the therapy and have that discussion with the patient right at the time of the visit, instead of waiting for the result of other imaging tests or labs or fecal calprotectin.
Are you training your fellows to do this, or is this something that you have in like an IBD center? You have a technician that's proficient in this?
Yeah, so actually now at this point, it is gastroenterologists with a specialty in inflammatory bowel disease doing this ultrasound in
Oh,
their clinic.
That's great.
And there's a whole module of training that we have to go through, and there's several modules. So it's a very there's a IUS organization that has a specific course, and of course there's the theory and what we're looking for and how to do
sure.
it, but a lot of practice.
Well, let's get back to our case. We have our 24-year-old. She's having these symptoms that we weren't quite sure if they were IBD, but then we found she has iron deficiency anemia, very high inflammatory markers. Her CRP was high. Let's get her CAT scan results, Elena, and then go on with the rest of the case.
Okay. Yeah. So the CT that she gets in the ER comes back with multiple enlarged mesenteric lymph nodes in the right lower quadrant. She also has pretty significant mural thickening of the terminal ileum and mural enhancement with tapering of the ileoluminal caliber to the ileocecal valve. There's approximately 25 centimeters of a segment of upstream mild small bowel dilation with mural thickening as well. The appendix also looks thick-walled and enhanced. So the patient is scheduled for a colonoscopy and an upper endoscopy after these imaging findings are also concerning for inflammatory bowel disease. So what would you expect to see on her endoscopic or in general on an endoscopic evaluation of IBD?
So this, our working diagnosis is Crohn's disease. And so what I expect to see on colonoscopy is active disease in the location that mirrors what is seen on the CT scan. So what is active disease in Crohn's? So typically what we see are ulceration. And these ulcers come in different shape and form and different severity. They can be small and aphthous, or large and round, or linear. And I probably will see some narrowing at the ileocecal valve that reflect what was seen on the CAT scan. And that narrowing can be mainly inflammation or often a mix of inflammation and scar tissue. And, my goal is from the colon, once I reach the cecum, is to get into the terminal ileum, see this inflammation, take biopsies, confirm the diagnosis, and get a sense of the severity of the inflammation. I might also see areas of inflammation in the colon that were maybe are milder inflammation and didn't get picked up on the CT scan. But in any case, in Crohn's disease, we were asking what differentiate from what we see on ulcerative colitis. In Crohn's disease, first of all, like we said, it can involve the colon, the small bowel, and in ulcerative colitis, it only involved the colon and always involved the rectum. So the location is different than the appearance on colonoscopy. In Crohn's disease, the ulcers are often in between ulcers, we often see normal mucosa, and we will see areas of inflammation where we see ulceration, and then areas that are normal, and then areas that are inflammation again. That's how we talk about skip lesion and patchy inflammation. In ulcerative colitis, the appearance is different. The rectum is always involved, and it could be just the rectum being involved, or the disease can extend more proximally up to a certain point. So it can be the rectum and the sigmoid, or all the way to the splenic flexure, or the entire colon. And so you see that inflammation in a more continuous pattern. We don't have skipped area or skipped lesion. So it's more continuous inflammation up to a certain point, and then it stops, and the rest of the colon looks completely normal. And then the inflammation in UC looks different than Crohn's. We have more of a granular mucosa. It's erythematous, it's red, it's friable, it's granular, and we do see superficial erosion or ulceration. We rarely see deep ulcers in UC, whereas we definitely see deep ulcers in Crohn's disease. So the location of the inflammation, the type of ulceration we see, whether we see continuous inflammation or skip lesion, all this can tell us if this is UC versus Crohn's disease. Very rarely, there are cases where a patient can have features of both. But in this case, with the involvement of small bowel, this is Crohn's. UC only affect the colon.
It's helpful. So this patient, she has the colonoscopy. It's notable for active inflammation and ulceration in the terminal ileum. There's also evidence of some stricturing at the ileocecal valve. The cecum and proximal ascending also have areas of deep ulceration. Biopsies are notable for acute inflammation, ulceration, granulation tissue, and crypt architectural distortion. So what pathology findings are typically seen in Crohn's and UC, and do you need to have the word chronic to make the diagnosis?
That's a great point. Absolutely. So the pathology findings for both disease are very similar. I often see a report that will say, the pathology will say, this is compatible with UC. And, on pathology alone, things are very similar. So what we're seeing are acute changes, such as neutrophilic infiltrate, crypt abscesses, but that alone doesn't make the diagnosis because you can see that with infection or with other pathology. So you see acute changes when there's active inflammation, but you have to see chronic inflammatory changes. And this is your crypt architecture distortion, Bannet cell metaplasia. So you have to have the combination of both. Now, if we're lucky, in Crohn's disease, we might pick up some granulomas. So granulomas are a cluster of immune cell, and they clustered. And we see that in around maybe 30% of the cases. So if we don't have granuloma, it does not mean it's not Crohn's disease. But if you have granulomas, then, kind of confirm your diagnosis if you want. But overall, in pathology, we do have to see acute and chronic changes to make that diagnosis.
So let's go on and talk about what treatments we might offer to this young person and what that might sound like. I know there's been a lot more drug classes since we last did this. I think we talked about like the TNF inhibitors and we talked about vedolizumab, but what are the classes and, how do you think through those?
Yeah, like you said, we actually are lucky that we live in a time where we have multiple effective therapies available to our patients, but also it can get a little bit confusing. And like you mentioned, anti-TNF, mainly infliximab, was really, they were the class of drug that really changed how we approach IBD treatment. We moved away from generalized immunosuppression with steroid thiopurine to biologic that target inflammatory cytokine and pathway. So infliximab, 1998, still very relevant drug. It was approved in 1998 for Crohn's and then later for UC, and still plays a role because it's such an effective therapy. But since the anti-TNF, we've had different drug classes and different mechanism of action, all developed to target as antibodies to target certain cytokine or inflammatory pathway. And then most recently, we had small molecule therapy. So these are chemical compounds that also target inflammatory pathway, the JAK inhibitor and the S1PR modulator. So biologic are our antibodies, and they're given as an infusion or an injection. We have the anti-TNF first drug class. After that, we had vedolizumab, which is an anti-integrin. The way vedolizumab works, it blocks inflammatory cell from migrating from the blood vessel to the gut. And because it's very specific to the gut, vedolizumab had a wonderful safety profile, mainly in terms of risk of infection or risk of, skin cancer. So vedolizumab was next. And then we had the anti-IL-12/23, ustekinumab, that blocks two cytokines, IL-12, IL-23, and that combine a lot of the efficacy of anti-TNF and a lot of safety similar to vedolizumab. And then most recently, I'm sure if you've been watching TV, you've seen ads of all these drugs, the IL-23 inhibitors, mirikizumab, risankizumab, and guselkumab. Very effective drug and also nice safety profile. And again, the thing to remember in terms of safety, it's really the risk of infection that is associated with biologic or small molecule. In the patient mind, they worry about the risk of cancer, and we can talk about that. But actually, the main risk with the biologic are the risk of infection, and those newer biologic have combined a good safety and a good efficacy. And then the small molecules, S1PR modulators that actually blocks the migration of lymphocyte from the lymph node to the blood vessel to the gut, and JAK inhibitor that block the JAK-STAT pathway are also very convenient drug because they're oral molecules. And the JAK inhibitor are really very effective therapies. Typically, we use them for patients more on the severe spectrum of inflammatory bowel disease or IBD with other associated condition or extraintestinal manifestation that could benefit from JAK. So we have a lot of drug class, and the way we choose a therapy in a particular patient really depends on several factors. What is the disease activity, how severe it is, what the course of the disease has been, what is the location of the disease, the phenotype. Are we, if it's Crohn's, is it a fistulizing type or anal disease? This is where anti-TNF and JAK inhibitor work very well, for example. Are they extraintestinal manifestation or associated condition like rheumatoid arthritis, psoriasis that could be co-treated by one drug? Or does the patient have comorbidities that would preclude them from using certain therapies? Are there any pregnancy plan? Is there, and then we also look obviously at the patient preferences and lifestyle. An IV infusion might not be the best mode of administration in a young person who travels a lot for work, for example, or who's going off to college. So we look at all this and make those decisions together with the patient. What we think is the most effective and safest therapy for the type of disease they have, the severity of their symptom, and the entire, medical history and their life plan.
Yeah, that seems like a lot of calculus that goes into that. That seems very personalized, the way that you're having to choose these.
It is. And that's why it's important to, when we're looking at the patient with inflammatory bowel disease, I always tell my fellows, you're not treating a GI tube, you're not treating just a GI disease, you're really treating a person with everything that comes with it. And you have to have this discussion and also align your goal as a physician. You want them to be on an effective therapy that's going to heal their bowel and not have to be flaring and being in the hospital. You have to align these goals to the patient goal, right? They want to be able to socialize and eat eat out with their friends and not feel left out at family gathering, or they want to be able to go out and date and not be worried about the diarrhea that's going to come about and having an urgent bowel movement. So you really have to understand what are the patient's goals of care and what is the patient expectation and what is their other medical problem and lifestyle, and really align those goals of care with your treatment targets, which is healing the bowel and preventing complication.
I think that dovetails nicely with my follow-up question. So let's say we start our young patient on infliximab, they come back 3 months later, they're feeling better. What is our target? I seem to remember I was just looking at our last IBD episode was 6 years ago, which was back when I was 20 years younger.
You
And
still look good.
thanks, appreciate it. So the smoking's a preservative, but no. But what I think, if I remember correctly, like we're sort of looking for like clinical and endoscopic healing, I guess. But I guess for you, so what is your treatment targets? What are you looking for? So it's great the patient feels better, but like what does what other responses from an endoscopic or histologic standpoint are you looking for just to evaluate treatment efficacy?
Yeah, absolutely. So you're absolutely right. 20 years ago, we just want a patient to feel better. But now we are, we want more, obviously, and the patient wants more. And that's the right thing, right? We want not just the patient to feel better, which we would, in medical term, we'll talk about clinical response. We want clinical remission, which means that we want no GI symptom affecting patient life. We want the resolution of extraintestinal manifestation if they have any. So no diarrhea, no bleeding, no urgency, no abdominal pain. We want them to restore, their normal bowel pattern. So, but in addition to that, we want endoscopic healing. So this is a very, a concept for the last few years, and that's especially important because endoscopic healing, when the bowel is healed, there's a decreased risk of another flare, another steroid, another visit to the ER, decreased risk of complication with, Crohn's progressing to stricturing disease or fistulizing disease and needing surgery, and also decreased risk of colon cancer that's associated with this chronic inflammation of the gut. So why are we not relying just on clinical remission to assume that the colon is also healed? That's mainly a kind of situation that happened in patients with Crohn's disease. In Crohn's disease, patients can feel well, but when we look at their bowel, they can still have inflammation. So clinical remission alone is not a good marker of what's happening in the bowel. There's often that disconnect. So that's why endoscopic healing is important. That's why you'll see us taking another look at the colon, even if the patient is doing well, because we want to make sure that the colon is healed. Now, a kind of a marker of that healing would be the fecal calprotectin and the CRP. If they were elevated originally and we see them now normalizing, then we're pretty sure that when we take a look at the colon, things are going to look good. So endoscopic healing is very important. But in addition to that, you really want the patient to get their quality of life back. So as I was mentioning, it's not just the GI tract that we're dealing with, it's a whole person. And IBD really affect a patient at so many levels, including their mental health, having the chronic illness, juggling appointment with doctors, getting colonoscopy when you're 20 years old and needing to repeat it every few years, that's not fun. Collecting stool for that fecal calprotectin, that's also not fun. The anxiety of the drugs, getting the injection or the infusion, taking the pill, monitoring labs, all this is such a burden that patients with IBD often, express, depression, anxiety, and it's important to address these things. This is a disease that often affects sleep pattern, psychosocial wellness, body image, sexual health. It affects the disease at so many levels that even though that's not maybe our immediate goal of care when we're treating, we want the healing and the endoscopic healing, that should be our ultimate goal. And that's what patients want. They want to get their life back and they want to be able to, travel and study and choose a job that they want and not worry about running to the bathroom or leaking or having abdominal pain or having, a skin rash that's just, affecting them. So we really have to look at that. And that is the ultimate goal of care, is for that disease not to be in control and for the patient to get their quality of life back and be able to live the life that they want to live.
The other primary care question that I get a lot, and I'm sure Paul gets as well, is just like, how do I have to eat differently now that I have this diagnosis? So, patients asking about, I'm sure you're getting patients asking you about the microbiome. They're asking you about like specific IBD specific diets. So how do you handle those questions?
Yeah, so we made a lot of progress in recent years because, and I don't know how, as a medical community, we were so stubborn by saying that diet has nothing to do with what's happening in your bowel. So, and honestly, I think it's patients who push for that. And now finally, the medical community is looking into the diet. So in terms of the diet, obviously when you're flaring, you're not going to be eating salads and fruits, right? We're going to have soft food. We're going to have things that are easy to digest. I often tell patients to avoid milk product because, especially if you have small bowel disease, when you have inflammation, you can have some lactose intolerance. So we're going to eat the things that are make us feel comfortable. But at the same time, we don't want to also become malnourished. So because during a flare, this is where your metabolism is higher. That's why often people lose weight. There's when your bowel is inflamed, we're often losing protein. There's a protein losing enteropathy. So we do need to get a good diet, but something that feels good to the GI tract, right? Does not bother us. So protein that you tolerate, whether it's eggs, ground beef, chicken, fish, protein supplements. Um, Again, salad and fruits are probably off for now. But if you can tolerate like cooked vegetables that are pureed, that's fine also. And you're going to need your carbs and good fat. Okay, so this is when you're flaring. Now, when we're not flaring, what should we eat? And again, a few years ago, we would tell patient avoid, any fiber, low residue diet for everybody, which is completely wrong. Because now we know in epidemiological studies that there's a higher risk of Crohn's disease or UC when the diet is poor in fiber, fruits and vegetable and legumes, and high in red meat, high in processed food. So we know that. Now, is eating a diet rich in fiber and low in processed food going to reverse that? We don't know. But I could tell you that once my patients are under treatment and change the way they're eating, where we're introducing, lean protein, vegetables in the form that they tolerated, whether it's raw or cooked or pureed, and we're avoiding processed food and ultra processed food and eating more of the typical healthy diet, my patients are feeling better. So that's what I recommend for my patient. Avoiding added sugar, the sodas, the juice, avoiding fried food, avoiding processed and ultra processed food. And I tell them the way you recognize that is anything that comes in a box or in a bag. That's processed. All right. You want to put on your plate food that you recognize in their original form. So the breakfast cereals that we've been told they're healthy for your heart and for you, these are ultra processed. These are not healthy. Have some oats instead, right? So avoiding these kind of food and favoring lean protein, fruits and vegetables in the form that you tolerate, the good fat, which are like olive oil, almond, salmon, avocado. These are your good fat, and your healthy carbs. So that's what I tell my patient. Now, of course, then we adjust in people who have certain complications. I'm thinking maybe Crohn's stricture, right? So if you have a stricture, if you have narrowing of the small bowel, but you're not a candidate for surgery yet, or you're waiting on surgery, we want to avoid, things that are very fibrous, your broccoli, your carrots, your celery, and really have more of a, smoothie type or a pureed, fiber while we're waiting for surgery to take care of the stricture. And I think it's important to talk about diet because patients are looking for a way that they can control things, right? And they can control what's happening to their body. And diet is a good way. And a healthy diet can improve on the gut microbiome. And we know that in IBD, there's gut dysbiosis. We have more of the pro-inflammatory bacteria and less of the anti-inflammatory bacteria. And diet is one of the elements that can promote a healthier gut microbiome, along with smoking cessation, good sleep, and physical activity. So it has to be part of a whole kind of lifestyle change if you want. It's not just popping a probiotic and thinking, your gut microbiome is going to be fine and happy. It's really that whole approach. And I think it's very empowering for patient to know that they're doing something healthier for their body. And people find difficulty changing their diet depending on what their baseline diet was.
I do think it's worth, Aline, just if we can sort of revisit some of the bread and butter preventive health screening stuff that is of special consideration for people with inflammatory bowel disease. So, like it's always nice to touch on the colonoscopies, but I know happen more frequently. But sort of what other stuff should we be especially mindful of? You mentioned skin cancer screening also a couple times too. So, what things along those lines should we be thinking about as we do primary care for these patients?
Yeah, it's a great question. And we always want the help of the primary care in, managing our patients. So, the main risk with biological small molecule is really the risk of infection. And the most common infections are upper respiratory infections, so your sinusitis, but also bronchitis, and then pneumonia. And so that's what we really want to prevent. And that's the discussion I have with the patient. Now, they're worried about cancer, and we'll talk about that. But in terms of this, that's why it's very important for our patient to get all their age-appropriate vaccine. They cannot get live virus vaccine when they are on immunosuppressive therapy, but they can get everything else. And what's very important for those patients, what we insist on is the pneumococcal vaccine, so your PCV 20 or 21, and the annual flu shot. And if they're older, above age 65, or they're on anti-TNF, they get the high-dose flu shot. So these are the two things that we really insist on. Also, what we recommend is the HPV vaccine, if it's age appropriate, and also the recombinant zoster, the shingle vaccine, the recombinant zoster vaccine, especially in patients who are going to be started on JAK inhibitor, because JAK inhibitor are really associated with a higher risk of shingles. But any patient above age 19 getting immunosuppressive therapy or about to get immunosuppressive therapy should also get the shingle vaccine. RSV in older patient and a certain patient with risk factor, and of course, COVID vaccine. Hopefully, our patient can will still be able to get it. So we really want to prevent the infections, and that's really important to discuss with the patient. Often, patients think that if they cannot have vaccine because they are on biologic or small molecule, or that vaccine could trigger IBD flare. And it's not the case. So very safe to take all the non-live vaccine if you're on immunosuppressive therapy. And if you're not on a biologic or small molecule therapy or thiopurine, you can have live virus vaccine. So that's a vaccine. Now, in terms of risk of cancer, really the main risk is the risk of skin cancer. And actually that risk is not from the therapies alone. It's just having inflammatory bowel disease. So recent data have shown that patients with IBD are at high risk of melanoma. So regardless of the therapy you're on, if you have IBD, you need an annual skin check. So that's for that. Now, in terms of the risk of skin cancer, there was a signal that maybe anti-TNF increased the risk of melanoma, but most recent data show that there's no association with melanoma. And there's also a signal for non-melanoma skin cancer. The main risk for non-melanoma skin cancer is with thiopurine. So that's your 6-MP isothiopurine. And more we're moving away from these drugs because the biologic and the small molecule are actually more effective and safer. But if you are on thiopurine, then you need an annual skin check to look for non-melanoma skin cancer. And that risk of non-melanoma skin cancer persists even if we stop thiopurine, because thiopurine causes DNA damage, and so we need to continue that skin check annually, even if we stop thiopurine. So if I would say two main things is the vaccines and the skin check. Now, biologics and small molecule do not increase the risk of solid tumor. It's not going to put patient at high risk of breast or colon or lung cancer. Okay, so it does not do that. There's a concern for risk of lymphoma and other heme malignancy. That mainly occurred when we were using anti-TNF with thiopurine, and that risk was mainly driven by thiopurine. So overall, in terms of cancer screening, it's the colon cancer after having colitis for more than 7 years, whether it's Crohn's or UC colitis. And then it's skin check anyway if you have inflammatory bowel disease, and even more so if you've been on thiopurine. But, I really recommend skin check for everybody.
And what about bone density? Like, which patients should be getting a DEXA earlier?
Yeah, so for bone density scan, that's a very good question. Our patients with IBD are at higher risk of osteopenia and osteoporosis. mainly after needing steroids. And unfortunately, up to now, there's a lot of clinician and often patients are reluctant to start effective therapy, and they end up being on several courses of steroids. So anybody who's been on more than 3 months of steroids, whether at once or repeatedly, a total of 3 months or more, need a bone density scan. But also, we have to think about checking DEXA in patients at higher risk of osteopenia because they're malnourished, or they have extensive small bowel disease, or they had extensive small bowel resection, or they're smokers, or have deficiency in vitamin D. So these are the patients that would benefit from a bone density scan, and then rechecking after they start on any therapy if they have osteopenia or osteoporosis.
Yeah, there's a lot to think about for these patients.
That's why we need the help of the internists.
Yes. And treating the iron deficiency, B12 deficiency in these folks, like typically nowadays we're giving the high dose oral B12. I just wonder if that's sufficient. And then should we jump right to IV iron for people thinking that they're too inflamed to absorb oral iron, or if they've had lots of resections that maybe they're not going to absorb it because of that reason?
Yeah, great question. So for B12 deficiency, this is mostly seen in patients with Crohn's of the ileum, so inflammation of the ileum, or they had ileal resection, or they had, extensive small bowel disease. Now, depending on the situation, I agree with you. I often use, 1,000 microgram of B12 orally. That's enough to overcome, what's going on in the ileum and correct the B12. But I still offer a patient, injectable B12 or intranasal B12, although the data on the nasal B12 is not very solid. But I often, offer option patient either oral or injectable. Again, recognizing that some patients are taking a lot of pills, some patients are already injecting and they don't want to inject more, or some patients will tell me, I'll forget taking a pill every day. I'd rather inject once a month. So we have a discussion, but whatever we choose to start, whether it's oral or injectable, I recheck B12 after 3-4 months. And if I see that it's not budging, if it's oral, then I know they need injectable. And if I'm injecting once a month, maybe they need a boost of once a week for a short period of time and then move to every month. So that's for B12. For iron deficiency anemia, like you pointed out, when there's active inflammation, there's upregulation of hepcidin, and hepcidin, what it does, it blocks the iron inside the cell, and also it decreases the iron absorption. So this is why oral iron is not always effective in patients with inflammatory bowel disease. So if the iron deficiency anemia is mild and the disease is in remission, then I offer oral iron. And I tell them to take the iron, like a formulation of iron with vitamin C to help with the absorption. But if they have severe iron deficiency anemia or symptomatic iron deficiency anemia, like the patient you were presenting, or they have active IBD and, we're still trying to control the inflammation, then I do IV iron, to bypass the whole issue about poor absorption when we have active inflammation.
Okay, so I think we're pretty much at the end of our first case, our patient with Crohn's. We diagnosed her sort of clinically between the labs, the CAT scan, the endoscopy, the histology. We were doing all we did a very individualized choice of medication. We came up with infliximab, and then we are monitoring for cancer screening, skin cancer. We talked about infection, so making sure we get vaccinations in before we start medications. And then now we're talking about kind of replacing vitamins, so oral iron and B12 depending on the patient, but some people might be getting injectables, especially if they're inflamed and they need iron. Anything else I'm missing there, Paul or Elena, before we move on to the next case?
Not masterful summary. This is why we pay the big bucks.
You're a pro. All right. So our next case, we have Mike. He's a 55-year-old, has a past medical history of left-sided UC. He's on chronic mesalamine orally, who presents to clinic with concerns for a flare. He has an increase in his typical 1 to 2 bowel movements a day to 4 to 5 bowel movements a day associated with urgency and blood in his stool. He has not been following with a GI provider regularly as he moved and has had many changes in his occupation and insurance during that time. So, think about this case for Mike. What signs and symptoms do you ask about when evaluating for a flare, and what initial evaluation would you send?
Yeah, so in your vignette, you ask about most of the question I would ask, right? So the number of bowel movement above normal, the consistency, the volume. Are they having nighttime bowel movement? That's usually is more severe disease when they have to wake up at night to have a bowel movement. Is there blood in the stool? And then it's important to quantify that, right? So with UC, the hallmark of UC flare is blood. So you always see blood with UC. And how often do they see the blood? Are these blood streaks or blood clots? Is it with every bowel movement? What's the amount? And then urgency is very important. And that's a symptom that really disrupt people's life more than anything else, that feeling that they have constantly to go to the bathroom. And it's important to ask not just about, do you have to run to the bathroom, but also how severe it is, right? So how often does this happen? How quickly do you need to get to the bathroom? Can you hold it for a few minutes or not at all? Have you had any episode of fecal incontinence? And again, the next step is how this is affecting their life. And when you ask patient, you'll be surprised how many are, you know, using diapers or pads, or uh, they not leaving the house because they need to be close to a bathroom, or they would only go certain places because they know exactly where the bathroom is, and how much it can limit their activities because they don't want to have an accident and have that anxiety of having an accident. So urgency is a very important symptom to kind of explore more with our patient, because for me, that's a also it gives me a sense of how bad the disease is affecting the patient, how quickly I need to make them feel better. And I'm thinking about choice of therapy, what therapy will control the inflammation quicker, because that urgency is preventing them from going to work or going to the grocery store and they're stuck at home. Also ask about abdominal pain. Did they need to modify their diet? Are they losing weight? Are there any extraintestinal manifestation, joint pain, rash, eye inflammation? And also I ask about any potential precipitating factor, like your patient was, he's just moved, he's has a lot of changes in his job and insurance, so maybe he's not taking his medication, right? Are you taking the medication? And always try to ask this question in totally non-judgmental way, because I know I'm bad at taking my medication. So I know anybody can, who's dealing with life changes could be facing that situation. Did the patient take antibiotic recently? Any NSAID, any travel, anything that might have triggered that flare, so that it can help me orient my evaluation.
What else are you sending here? I mean, I usually see people sending stool studies to rule out like an acute infection, but what any other specific labs or studies you do right here seeing this patient?
So definitely stool studies to rule out infection, so stool culture, but also don't forget about C. diff. So C. diff is one of the most common precipitating factor for a flare, and increases severity of the UC flare. So always checking for C. diff. And obviously inflammatory marker will send the fecal calprotectin to get a baseline. I know he's inflamed, but it's really important to kind of get a baseline for the treatment and your labs, right? Looking for anemia, a white count, creatinine. Is there any evidence of dehydration? Because, these are factors that will help me determine, can I wait to get approval for a biologic, for example? Do I need to use prednisone to control things because this patient is not doing well? Or do I need to send this patient to the ER to get admitted because they're dehydrated, their creatinine is up, their white count is up, their hemoglobin is 6, and we really need to manage them in a hospital setting?
Yeah. Is the intestinal ultrasound something else you're pulling out in your clinic when it's available for someone like this?
If it's available, this is a great way to kind of take a quick look and see if there's a bowel wall thickening, if there's increased blood flow. Then we know that the patient's flaring. It's not alone. It does not determine the severity of the flare. So, but it's definitely an added tool to have the whole picture.
That's helpful. So let's say Mike, he's febrile. He gets his labs. His creatinine is elevated. His white count's elevated. His blood count is down to like 7, but it was previously normal. So really more concerned that he needs some urgent evaluation and care. So you send him to the ER, they admit him, and while they're waiting on additional tests, they start him on some IV steroids. What additional recommendations would you have at that point for acute severe ulcerative colitis while he's in the hospital?
Right. So for acute severe UC, there's criteria for the diagnosis, which is, having more than 6 bloody bowel movement per day, anemia, high CRP, tachycardia, fever, so systemic symptoms also. So acute severe UC definitely belong in the hospital, but also like you pointed out is even if it's not acute severe UC, but the patient is having debilitating symptoms, weight loss, dehydration, or they're at risk of all these, like it's an older person or somebody who doesn't have anybody to help them take care of themselves, or if we don't have access to effective medication soon, these patients belong to the hospital. And sometimes, just by looking at the patient, they look sick, they belong to the hospital. So a physician assessment is also important. But for acute severe UC, we have guidance on how to proceed because it can become a medical and surgical emergency very quickly. So we take it seriously because patient can develop complication of toxic megacolon or perforation that would need surgery. They can hemorrhage. They can go into renal failure. So it's very important to act quickly and coordinate with the different team members. So what does that mean? So steroid and fluids, right? We're doing the stool studies to make sure there's no C. diff, no infection. We're getting our labs. And when we get our labs in a patient like this with acute severe UC, we're also including our TB testing and hepatitis B testing in anticipation for potential infliximab, or more recently also sometimes we use JAK inhibitor in the context of acute severe UC. So the original lab should include the TB testing and Hep B testing, TB testing, so quantiferin gold or T-spot. And then Inflexic should be done within a day or two. We don't need a full colonoscopy. We just need to see how severe the disease is and take biopsy for CMV that could be, present in this case. And then it's important to monitor the patient very closely. Now, I like to get my surgical consult early when a patient admitted with acute severe UC. The guidelines say, within 3 to 5 days, or if the patient is not responding to steroid. But more and more now, we recognize that surgeons have to be involved early. Why is that? Because things can, turn south very quickly, but also because you don't want to show up on day 3 or 5. Things are not going well for the patient. Tell them, well, now you need surgery, you need a colectomy. That conversation never goes well. So having that surgical consult early on allow to have these conversation and allow the patient to be prepared in case medical therapy alone does not control the inflammation, or in case a complication happened. They've already met the surgeon, established that trust and that relationship with the surgeon. Now, in terms of care, in addition to the fluid and the steroid, it's very important to place the patient on DVT prophylaxis. And DVT prophylaxis is not going to make the patient bleed more. Patients with acute severe UC are in hypercoagulable state. Any active IBD flare is a hypercoagulable state, but even more so when we're dealing with UC in the hospital. And so DVT prophylaxis is absolutely important to avoid DVT and PE in those patients. So once you start this treatment, monitor, serial abdominal exam. And typically on day 3, we need to assess the response. And a response means number of bowel movement, bleeding, CRP have decreased by 50%. If they haven't, steroids are not doing what they're supposed to do. And this is when we think about what we call rescue therapy, which is infliximab or JAK inhibitor or surgery, depending on the situation.
That's helpful. So let's say, we kind of talked about Mike coming in with a flare. In his case, it was more severe, so we sent him to the hospital. Let's say his labs came back and they were not as concerning, his vital signs were okay. What medicines would you reach for at that point as an outpatient to help?
Right. So, in this situation, we would say mesalamine are not working. I would definitely do a Flexic to assess the disease, and his disease might have progressed from mild to now more moderate to severe. And we have a choice of therapy, right? Now, often ideally, it would be great to start a therapy and not have to use prednisone in between. But he's fairly symptomatic. He has urgency, and it takes time, as you know, and sometimes a lot of back and forth with insurance to get prior authorization for these more advanced therapies. So often we're going to use prednisone, oral prednisone, to control the symptoms while we're starting the therapy. And here are the choices that we have. Honestly, we could use any of these therapies. In this situation, I probably will go with a IL-23, because it's effective, it works quickly, and it's has a good safety profile. Vedolizumab is also an option in terms of safety and efficacy, but it sounds like he travels a lot, and maybe an IV infusion might not be ideal for him. But all of these are on the table, but we narrow it down by the fact that he has only luminal disease, right? I don't know, maybe he does have extraintestinal manifestation, but for now he has only luminal disease. His disease has progressed to moderate to severe, and I want to choose a therapy that works quickly, that's safe and effective. Now, if on my endoscopy I really see severe disease, then this is where infliximab come to play. Because it acts very quickly. I can adjust the dose, and it works quickly, and it's easier access than other biologic. If it's somebody that's already been exposed to infliximab and now not doing well, this is where we can consider JAK inhibitors. So the JAK inhibitors are only approved in the US after failure or non-response to anti-TNF. So it's important to have these discussions with the patients, pros and cons, and then come with a shared decision making with the patient and choose the right therapy for them.
When I was reading the guidelines, they mentioned like the antibodies and the drug levels. Is that something that you're expecting general internists to order or interpret, or?
No.
Okay.
No, even as gastroenterologists, that's a lot. So we really do it. So this is not something, our main ask, if you want to know how the internist can help us, is the health maintenance, help us with addressing, mental health, pelvic floor dysfunction, everything around. Drug levels are really more of like fine tuning for the gastroenterologist, and it's mainly with the anti-TNF, so infliximab and adalimumab, because these are drugs where the metabolism of these drugs by the body, or when the colon is inflamed, we can lose infliximab and adalimumab in the stool, so the level goes down. So this is for us to actually check for levels, monitor for antibody, adjust then the drug dose and frequency to reach the right drug level. That is really something that the gastroenterologist should be doing. And if you're doing that for your GI, I'm like, maybe I need you to have as my primary care doctor, because that's a lot of things to do.
Well, Matt's accepting patients, because I will absolutely not be doing that. But if you're ever in Philadelphia,
Right.
you know where to go.
Yeah.
I did want to ask, because often I'm seeing these patients who are having flares of their extraintestinal manifestations. So, and maybe that's because I'm more accessible, or it's maybe perhaps less traumatic. I'm not really, I'm not sure what the circumstance, but like I'm thinking specifically of like the axial spondyloarthropathies. Like my back pain's killing me. I think I'm going to flare, and I'm tempted to throw some prednisone at this person. But I guess or sometimes even ocular manifestations too, or maybe someone has a history of like uveitis or something, and it just sort of makes me a little bit sort of nervous enough to. But to do something, but I'm not entirely sure what. So I guess how, from your standpoint, what's sort of the best way to sort of manage the acute extraintestinal manifestations as they flare up? Because that's the things that I tend to be asked to deal with more directly than sometimes the GI manifestations.
Yeah. I think as gastroenterologists, we are responsible for asking about EIMs. And again, we often focus on the GI tract, and it's very important to ask about EIMs, because that can affect what kind of therapy we can choose, right? So if somebody who comes in and has uveitis or arthritis or ankylosing spondylitis, the best therapies would be anti-TNF or JAK inhibitors. So it's important for us to ask about this, so that we choose the right therapy from the start, and then you're not dealing with, somebody maybe who is on IL-23 or Vedo and now having joint pains, because these drugs don't address the joint pain. Now, having said that, sometimes these manifestations don't happen initially at diagnosis and happen during the course of the disease. And then we have to have this conversation, or do we switch therapies, or do we add another therapies? So in terms of EIM, the most common ones are the joint, right? So the spondyloarthropathy. So it's the joint, and most often it's the peripheral joint. And we can categorize them in type 1 and type 2. When type 1 is like the large joints, and few joints are involved, and they typically follow the course of the GI disease. So when the bowel flares up, then those big joints flare up. They're painful. Patients complain about that. And sometimes the joint pain precede the GI symptom, but I know the GI symptoms are going to happen. Or they have Crohn's disease and they don't have any symptom, but there's active inflammation on endoscopy. So in that case, for these large joint pains, in theory, any therapy that control the GI illness should control these joint pains because they're parallel. Okay. Then the type 2 peripheral joint pain are the small joints, and the hands, and most of the time it's the hands. And these can be completely independent of the IBD activity. And these are more of a challenge for us, the rheumatologists, to treat, right? Because they're already on therapy, their bowel disease is controlled, but they're still having these painful joint pain. And so this is where we think about adding therapy like methotrexate, or topical therapy like Voltaren cream. And I think this is really important to engage with the rheumatologist and have their help. And then we have the axial spondyloarthropathy, right? The inflammatory back pain, the sacroiliitis, and the AS. And these are typically independent of, again, the gut. And what's most effective is the anti-TNF and the JAK inhibitors. So this is when, the conversation have to go, right? Between the primary care and the GI and the rheumatologist, how can we best serve the patient with the right therapy? Do we switch therapy? Do we add another therapy to control this? Uveitis, as you mentioned, is an emergency, so they do need to see the ophthalmologist and start steroid. And again, if this is somebody who has uveitis, recurrent uveitis, this is where anti-TNF plays a role. So it's interesting that, we talked a little bit how some neurotherapy have better safety profile, like the IL-23, IL-12-23, the vedolizumab, but anti-TNF still play a big role, especially for IBD with extraintestinal manifestation.
We are sort of at the end of it here, right? How do you know when someone needs TPN? Is that more of just like a nutrition evaluation, or does that come from gastro or surgery?
So in patients who are admitted in the hospital, we always prefer enteral nutrition, right? So whatever they can tolerate, unless you're thinking they're going for surgery and they need to be NPO. We try to avoid TPN because, again, the patients with acute severe UC or IBD flare, they are in a hypercoagulable state. So the TPN will put them at higher risk of upper extremity DVTs. And also there's a risk of catheter infection, right? We're dumping steroid on them, and then we're adding infliximab, and they have a line in. So the times that I use TPN are the times where, it shouldn't be in a situation where, that's the only thing we're doing for the patient to keep them out of surgery. So if a patient with, for example, stricturing Crohn's disease, we're planning surgery because the stricture is obstructing, they haven't been able to eat, they're malnourished, they lost weight, and even with enteral supplement, we're not able to kind of get their nutrition going, then TPN can be a temporary measure to improve their nutrition and make surgery safer. So then when they go to surgery after a few weeks to resect that stricture, they're not malnourished, which would put them at high risk of infection and poor wound healing and anastomotic leak and all kind of surgical complication. In terms of acute severe UC, I would use it maybe very temporarily in somebody who has had a bad flare. Now I control the flare with, a anti-TNF, infliximab, or another therapy, but they were so malnourished when we got to them that they just need TPN for a few weeks until they get transitioned to while they're still eating, and then maybe supplement later with enteral nutrition. So TPN should never be something where somebody is on for several weeks waiting for treatment to work, because if the treatment we're using, the biologic or whatever we're doing, is not working and the patient cannot eat and having bad diarrhea, and we're using TPN so that they are NPO and minimize their symptoms, it means that medical therapy needs to be changed. So it's kind of like a crutch. It's never like a longer term therapy because of the risk associated with that. And because it means that the medical management we're doing is not working. We either have to change medical therapy, or we have to consider surgery, total colectomy, in somebody with severe UC that's refractory to different therapy. So it should always be very limited, the TPN. Unless, extreme circumstances, somebody who's had multiple small bowel resection and has short gut, they're TPN dependent. We get that. But in terms of like managing Crohn's or UC, it should be temporary until either the surgical solution or the medical solution is made available.
Well, I think we've saved both patients. So Mike, we
did a great
connected.
job.
Yeah.
We connected Mike with a rheumatologist. Got his back pain better. His ulcerative colitis is treated by the vedolizumab. So I think we've done really great work. But now we need some take-home points, and we need to let you get back to your two fighting cats
And the chickens.
and the chickens.
The chicken is sleeping now. It's great.
Yeah. So what would be some like 2 or 3 take-home points you want the audience to remember about our discussion?
Yeah. I think what I would say is IBD is definitely on the rise. The demographics have changed. We used to think of it as a disease in Caucasian or people from Jewish descent, but it's really affecting everyone. And Blacks, Hispanics, immigrants are all at increased risk of IBD. That we're seeing, increase in the incidence of IBD. So IBD is becoming common and with people of all backgrounds. So in your practice, you will see somebody with IBD. So I think it's very important to really familiarize with the symptoms, the presentation, the workup, recognize the symptom, recognize the extraintestinal manifestation, and refer to the specialist, as soon as possible. Because any delay in diagnosis can lead to an increased risk of complication and ending up in the hospital or ending up with surgery. So recognizing the sign of symptoms, managing IBD, like we pointed out at various times during this conversation, is really a multidisciplinary matter, right? So the internist, the primary care doctor, the GI, the rheumatologist, surgeon, but also a dietitian and the psychologist, and sometimes infectious disease and dermatologist, and everybody. So it's important to really find the team that you can reach out to, that you trust, right? And create those connection of people who are interested in taking care of patients with IBD. It's important to really become familiar with the health maintenance. We talked about the diet. Often the internist is being the one being asked the question. I think we talked a little bit about what a healthy diet is, but also there's this whole thing about the Mediterranean diet, which is a great diet. But I think we all have to recognize that it might not be the diet for everybody. Somebody who is from Caribbean descent or South Asian descent, telling them have a Mediterranean diet doesn't mean anything for them. So it's important to adapt the diet to the culture and the preferences. And it could be the same principle as the Mediterranean diet, but adapted to the person that you're treating in front of you, because just telling them have a Mediterranean diet might not mean anything. So really talking about diet, healthy lifestyle, health maintenance, but also addressing the issue that matter to the patient. How they're feeling, how they're doing emotionally, how they're managing with their medical bill and the cost. People are very proud and might not tell you that all this is costing them $1,000, and there are always ways to help patients, through different patient support systems. So it's important to talk about these patients and establish a relationship of trust that will allow them to talk about how this disease is impacting their sexual health and their fear for pregnancy and what needs to be done and the money and the cost and the restrictions. So that we are able to address these issues together. So I would just say that IBD patients are probably some of the most resilient people I've met. They humble me and they inspire me every time. And the most important thing we can do for these patients is really to establish this relationship of trust, that they can tell us what's going on with their disease and their life, but also establish that circle of physicians of different specialty. And at the center, we have the internist and the primary care doctor coordinating and managing a lot of the issues so that we can provide the best care for our patients.
That's what Paul's here for. All right. Well,
and comic relief. Yeah.
Yeah. All right. Thank you so much.
Yeah.
We really appreciate all your time and teaching. And tell your cats, take it easy on each other.
They will.
Okay.
Tell them we said pss, pss.
I'm
Paul,
gonna give them some chicken nuggets and they'll be fine.
Yeah.
Perfect. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
The felt gratuitous. Still hungry for more? Join our Patreon. Get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME for all health professionals through VCU Health at curbsiders.vcuhealth.org. Special thanks to our writer and producer for this episode, Dr. Elena Gibson, and to our whole Curbsiders team. Our technical production is done by Podpace. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chumanchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
Elena Gibson here.
And as always, remain Dr. Paul Nelson Williams. Thank you and goodbye.